Great. Good morning, everyone. We are here Wednesday morning at 8:30. Thanks for coming in early. Thanks for everyone on the line to talk about the governor's proposed fiscal 24 budget, therapeutic alternatives to emergency department in the Northeast Kingdom. We just received information, so there is an email from Claire, and she will also post it for testimony related to this testimony. And we have, for this topic, we have Allison Crump with us from the Department of Mental Health. And Kelsey, I am sorry, I'm not even going to try your last name.
Kelsey Stavseth.
Stavseth, thank you very much. The Executive Director of the Northeast Kingdom Human Services. Looks like we have Nicole too. So anyway, I'm going to turn it over to Allison to take the lead, and then we'll bring in Kelsey whenever it's appropriate.
Great, thank you. Good morning, everyone. For the record, I'm Allison Crump. I'm the Deputy Commissioner for the Department of Mental Health. I do apologize. I have a hard stop at 9. We're heading off to a family vacation and my flight leaves. So, but I think we can get through what we're here to talk about today. And I'm grateful to see Kelsey here because he can give you more of a deep dive into the program and answer those types of questions. But I want to give you a sense of how we got here and kind of what the assessment of need has been up until this point. And so I thought I would start here. This is a map that we have brought to House Healthcare for years now, as well as other committees. And it's a map of where the bed resources are in the state. And since the time I joined the department in 2018, every time we show this map, we have a committee in the legislature who says, there seems to be less resources up in that yellow section of the Northeast Kingdom. So it's something we've had our eye on for some time on trying to figure out what is the need, how do we best leverage resources, and what type of resources. And so if you go to the next slide, Nicole, I'll talk about kind of the interesting way we got here, but I'll pause. It sounds like you might.
Yeah, Allison, I'm just going to have you pause for a minute. Is everyone good of where we are? I'm not sure we have Allison's presentation. So
Okay.
hold on.
Just have the budget narrative.
Hold on, Allison.
Sure.
We have did we get that, Claire?
I got a letter
We got the budget.
from Emily Hodge.
Hold on 1 second. Allison, have you sent this to us?
Nicole, do you know if we forwarded it yet?
I don't think we have.
Okay, so we're watching it on the screen, but Nicole, if you can please send it to Claire.
I can.
Thank you. All right, sorry, Allison.
No,
So it's only on the screen for committee members right now.
Okay. All right. Thanks for letting me know. And that's on me. I want to make sure my policy, Nicole's on top of everything. So it's surely that I didn't get it to her in time. So I think what I wanted to make sure this group is aware of is this project has come about through a few different avenues of a swelling of support. And so the first one I did want to highlight the Barrett family. So Chris and Betty Barrett have been advocates in the Northeast Kingdom, kind of trying to shine a light on their perspective that there were not enough mental health resources. And specifically, Betty's been an advocate for suicide prevention. She lost her son to suicide and has been a loud voice trying to share her experience and speaking about how in her region, she felt like if somebody needed urgent help, they had to go really far to get it. And there were some real barriers. And so since her persistent voice, she's a member of the Suicide Prevention Coalition. We have a statewide coalition, which that family started working with some community advocates in their region. And there was a lot of coalescing around this. So what happened from there is they worked with some of their local providers, community leaders, and local legislators to talk about this need. And they came together to present a proposal to the Department of Mental Health. This was almost 2 years ago now, about a year and a half, in December of 2021. And so they also reached out to the governor's office talking about this gap and this need. So the department set about trying to figure out, when we hear the term mental health facility, that can mean a lot of things. And so we went and looked at really what is an assessment of the need in that region, and kind of helped the Barretts and the group figure out, when we say facility, are we talking inpatient hospital all the way down to, respite beds or peer beds? Where on the spectrum are we thinking this need is? And so we kind of started shaping it around our state assessment of need. And what we did first was we said, we don't think we're talking about an inpatient psych hospital here. We're talking about a community-based resource. And, how do we figure out how much the Northeast Kingdom needs there? And also, if we're going to put a resource somewhere, why the Northeast Kingdom? So we started looking at the numbers in that region, and I wanted to highlight a couple things for this committee that stood out to us. One is, out of the top 4 counties with the highest rates of suicide deaths in the state, 2 are counties in the Northeast Kingdom, Orleans and Caledonia. So that definitely struck us as this need for suicide prevention resources. And then we also looked at an interesting statistic that we've been looking at for all agencies, all DAs across the state. And that is, of the people who go into mental health crisis in any region of the state, how many of them are served where the location is an emergency department? And there's a few other choices that you can be seeing besides an emergency department. We've got schools, community, home, office, and emergency department is, like the 6th one. And so in the Northeast Kingdom, we found they had the highest rate where the location of service was emergency department. About 31% in the original data that we pulled in 2021 were seen in that location, versus an average in other states around 13% in other regions of the state. And so I bring that up because it told us that there weren't a lot of other places to go, and that, particularly NKHS was having to meet people at that location for lack of other therapeutic alternatives where somebody could walk into in an urgent manner. So I will tell you what happened from there. We, as the department, worked with this group to say, we like the idea, we think there's a need, we want to leverage existing resources. And so we started talking with NKHS. They had had a recent leadership turnover, and Kelsey and his clinical operations person, Joe, really stepped up and started working with this group on, what type of program we think was most needed. And we were excited about that prospect because it meant we were leveraging existing resources and building upon something that already existed. Because right now with the staffing crisis, we didn't think logistically we could place something separate in that region, outside of an existing resource. So we took that, we incorporated some best practice crisis models and zero suicide tenets. And I put a link to those in here in case anybody's interested in kind of what the state is looking at when we say those words. I know we've talked to this committee about what zero suicide is, but there's other best practice crisis models out there, and you're seeing them in some of our initiatives. So we're working on mobile crisis, we're working on alternatives to EDs like urgent cares, and that's where this fits in. It's the place to go piece to the crisis continuum puzzle. And that all shaped into this current proposal. And so I know, you may have other questions about the program, but I thought I would give you, just the highlights from the department's lens of where we've landed and what NKHS is putting forward. And so you'll see it called a couple things right now because we don't have a name for this treatment center. But I'm going to use the term Urgent Mental Health Crisis Center because I want to make sure that the committee understands this is different from, it's not a hospital-based setting, it's in the community, and that it's required to have urgent access, meaning that you could have police bring someone there, someone could drive a loved one there. It is a place where you can walk into and be served. And so it would be run by the Northeast Kingdom, and we intend for it to serve individuals experiencing suicidal ideation or a mental health crisis. Given, you know, the broad needs in the region, we didn't want to limit it to just suicidal ideation. However, there is a real focus on that issue, and you'll see it in the work that they've put forward on programming. So we're looking at a person-centered therapeutic setting. This goes back to when we were charged with doing some stakeholder engagement around the long waits in emergency departments. We talked with lots of families about their experience and what it was like going into emergency departments or seeking access to care at all in an emergency. And they talked a great deal about how they really wanted a therapeutic setting and they really wanted a different place to go besides the emergency department. And yes, sometimes they'll need to go there, but their preference would be to have the option for something else if, you know, there wasn't a medical emergent piece to their need for care. So we've asked that there be actual treatment provided there, which I know has been another issue. If you're held in the emergency department, there's very little treatment that you can get right now while you're waiting. And so this would be a space to get treatment and then be followed up for care. We want to make sure it's community-based and can divert individuals away from both emergency departments, and police involvement is another space that we're trying to reduce the numbers. And then we felt it did align and build upon Northeast Kingdom Human Services' other established programs. So I think this committee is aware NKHS is one of our certified 988 centers. In fact, they cover the line most of the hours, including nights and weekends. And that was something I will say, you know, when we think about capacity in a region and how they're able to serve and pull together with some of these larger efforts, NKHS's ability to fulfill that need was part of what made the department confident that we felt they could step into this space. And I think Kelsey will talk a little bit about how they'd be leveraging, you know, some existing emergency services and CRT programming to help with the foundation of this program and kind of connect the dots in their continuum of care. So I just said a lot, so I'm going to pause and see what questions you have before we turn it over to Kelsey.
Great, thanks, Allison. So I just have a question about the money that I want to make sure I get in before 9. So it looks like it's a ask of 1.6, I'm rounding up, $1.6 million gross with the state ask of 691,000. Is that one-time funding or is this going into the base request?
Base.
Okay, so the expectation is that setting this up and then it will be in the base. So it will be a long-term project versus a pilot, which would be one-time funding.
Yes.
Okay, great, thank you. Any other questions for Allison? We'll hear more about the, you know, what NKHS can do. Do you have a question?
Do you mean she's going to talk about staffing and services and whatnot?
Right, I think Kelsey will walk through how they will roll it out with staffing and services. So any questions specific to DMH's desire to have this or the reason they put it into the budget? Leslie?
I'm just wondering, Allison, if there are other equivalents in other parts of the state?
Yeah, in a few ways. So you'll see the department has been seeking to fill a gap, which we see as alternatives to emergency departments. There is a PUC in Bennington that you may have heard of. That's psychiatric urgent care for kids. So that is, we'll call it, it's not the same model, but it's a similar vein and idea of having an urgent mental health care model. Again, this one would be for adults. That one was geared towards children. Similar to that, the Bennington region did develop a partnership with their local hospital to talk about, hey, how would you know when somebody may be best served here versus there? And did some coordinated marketing of those resources to the community so they know, you know, when's the right time to show up to emergency department versus the PUC and what can you get in different settings. And so I would liken it to that, but it's a little bit more robust in its hours and it'd be serving adults.
So then there would be 2 places in the state, one in Northeast Kingdom, one in Bennington. You gave that example. Are there others in other parts? I mean, we know we want to move people out of the emergency rooms and make sure they have access, et cetera. So what happens in Wyndham County, what happens in the middle part of the state, what's your thinking of that?
Yes, we put out a request for proposals for others. So we offered an option of kind of a list of options that people could choose from. And so we're in the process of allocating funding to try some other projects as well. That's through one-time funding through HCBS FMAP. So we are looking to invest. We have a project in Chittenden County that we're interested in, a partnership in CSAC. We could give you the list of current awards that have gone out. I think there are 5 at this time. And so those are more sort of testing out models. This one is the furthest along and the most developed with a broad list of stakeholders. And so that's why it was moved into the non-pilot phase and an ongoing budget ask. But we are hoping to stand up others.
Okay, so I understand that you have a series of proposals that are one time that you're looking to get responses to, and then once you get that, you'll turn it more into an ongoing program and an ongoing budget request.
Yes, we're really interested to see how, regions can shift how they're working to create a different entry to care. And so that will help tell us kind of what that budget ask is, because I do expect it'll be different in different regions that have different resources and different buildings. So yes, we'll be learning a lot in the next 2 years about this.
Thank you.
So Allison, I think that's a great point. Thank you, Leslie, for asking the question. I just made a note that we'll probably want you to come back in, even if it's, half an hour, just to give us more details on the 5 proposals that have been put out, or whatever you call it. And then kind of what you're doing over the next 2 years to track the success of those programs. So that'd be great. Anything else for Allison?
I have a quick question.
Yeah.
How does this connect with, in my county, Washington County Mental Health, which is, how would it connect with that agency?
So this particular program, we have asked MKHS to be able to consider it to be a statewide resource. And so if there was, availability at the space and someone in Washington County needed to be served, that they would be able to consider, accepting that person. And I don't want to speak for Kelsey, but we have talked about that, and it's listed in the project that it would be a statewide resource until more regional options are built.
Okay, thank you. Great.
Thank you, Allison. Kelsey, are you going to share your presentation on the screen? Would be.
Have a good vacation, Allison.
Bye, Allison. Thank you.
Yes, I'll share my presentation on the screen. I was intending to read my written testimony, but I don't want to use up time either if that's already been submitted. I would defer to all of you.
Whichever you feel is going to be most impactful for us to understand what you're trying to do. Okay. I will let you decide. And what I think I'd like to do while you think about that is I want to do a quick introduction, since this is the first time in your committee with us, and then I'll turn it over for you and you can introduce yourself, and then we'll figure out how to move forward. So Bobby, would you like to start?
I'm Bobby Farley-Rubio from Barnet, and I also represent Reigate and Waterford.
Alan DeMar representing Enosburg and Montgomery.
Alyssa Black, excuse me, representing Essex.
Lori Houghton, City of Essex Junction.
Topper McFawn, I represent Barrytown and a piece of Williamstown.
Mari Cordes, Lincoln, Bristol, Moncton, and Starksboro. Daisy Rebecca from Winooski.
Leslie Goldman, Wyndham 3, Brookline, Rockingham, and Westminster, which is the Bells Falls area.
Art Peterson, representing Clarendon, Wallingford, West Rutland, and a piece of Rutland Town.
Great.
I'll read the prepared statement, which hopefully will only take a few minutes, and then I'll do my presentation here. But
okay, great.
First of all, thank you for having me. I really appreciate that. And I do want to just emphasize what Allison started with, which is this was done in thoughtful collaboration with the Barretts, with DMH, with our partners here in the Northeast Kingdom. And I really want to emphasize that the success of this project and the work that we've done is done through collaboration with the community and with our many partners, which I'll talk about a little bit more in my presentation. And so I'm here to support the Therapeutic Alternatives to Emergency Department in the Northeast Kingdom for the allocated amount of about 1.6 million as specified in the governor's budget. And so we're calling our ED alternative the Front Porch, and its purpose is to provide a specialized mental health treatment facility and programming specifically for individuals experiencing suicidal ideation or in a mental health crisis in the Northeast Kingdom, with expanded availability to other community members statewide. This facility will provide crisis stabilization, best practice interventions such as dialectic behavior therapy, collaborative assessment and management of suicidality, also known as CAMS, and other clinically indicated supports. Staffing at this facility will include licensed clinical professionals, direct service professionals, and peers with access to nursing, psychiatric, and medication management services. This facility will provide a community-based option for those in crisis and divert individuals experiencing a mental health crisis away from emergency departments. In doing so, this facility will provide a more person-centered and therapeutic setting for stabilization, interventions, treatment, and referrals for follow-up care. This program would fill a substantial gap in the current continuum of care and alleviate the strain on other community partners like our hospitals, emergency responders, and law enforcement. It also aligns with Northeast Kingdom Services' other established programs like the 988 Crisis Call Center, Mobile Crisis, and CRT programming, which would improve the overall efficacy of already established community services. There's long been a need for expanded mental health supports in the Northeast Kingdom, specific but not limited to suicide prevention. Current services for acute stabilization and treatment are limited. When people in crises seek out support, they often call 911, where first responders currently have no other option but to transfer to the emergency department at the local hospitals. Hospital employees are not adequately prepared to treat suicidality or mental health crises, and the environment in emergency rooms are neither therapeutic nor adequate and can often traumatize, escalate, or worsen the situation. A designated mental health crisis center would provide mental health specific supports by trained professionals in a therapeutic environment. So we've designed a freestanding 24/7, 365 Front Porch Crisis Care Treatment Center with open access and immediate response for adults and families experiencing mental health crises. The center will create the most appropriate door for accessing supports and treatment. Those in mental health crises seeking help through 911, 988, or hospitals could be diverted as appropriate to this facility. The treatment facility would also be open for walk-in supports, mirroring programs like mental health urgent care initiatives and psychological urgent care for kids, PUC. This treatment facility would be a priority drop-off support for first responders supporting individuals in acute mental health crisis. And the person in crisis would be welcome to the Front Porch hub to meet with a professional or peer, take time to acclimate to the facility and feel safe and heard. And there will also be an array of modalities to support the individual when they are ready. And then I would just like to add, in addition to supporting the funding for this project, the designated agency system, which we fully support, is also asking for a 10% Medicaid rate increase to stabilize current staffing and enabling us, as well as other DAs, to respond to an increasing need for supports. This project is only strengthened by the strength of our other programs as they all work together to enhance each other. And so having a solid continuum of care will ensure that people who need the right supports at the right time will not end up in the emergency department. The Front Porch program is closely tied to the success of our other programs, which need rate increases to fill significant vacancies. It is worth the investment in upstream preventative services, which ultimately saves money in the system of care. So I will share my screen.
Thank you. We also have, we can see it. We also have this presentation, everyone, on our committee page. Great.
Okay, so Allison touched on this a little bit, but the development of this program was really intentional. And so this is from SAMHSA best practice. And so with permission, we were able to utilize this graphic from the Missouri crisis model, but it explains nicely in visual form what we're going for. And so as you can see, Northeast Kingdom and Northwest Counseling, our sister DA, run the 988 call center 24/7. And like Allison said, we do a bulk of the hours, nights and weekend. And we also just recently picked up text and chat. And so we have these upstream services. We also have our emergency services, and we're working towards mobile crisis to Fidelity, which includes peers. And then the gap is right here in what we're calling our front porch. And so this would be where the program fits. And so as you fill out this continuum, you can have a softer landing for folks who may be coming out of inpatient or prevent them from even visiting the hospital as they need a safe, therapeutic, and purpose-built space to go if 988 mobile crisis or some of our other programmings cannot defer or divert them from a physical location, which right now in the Northeast Kingdom is the hospital. I'd also say that this models other programming. So this is, we've taken into account youth crisis and saying, again, 988, someone to respond. We do have people that go out into the community, but then we need that safe place to be. And so our intention is to be able to host adults and children. And so this is the purpose. What is going to be different? What happens if we have this? And so the programming is going to be, meeting the person where they're at and their unique needs, providing treatment, increasing our capacity to address these specific issues as they escalate to needing a physical place to be, and then appropriately using our resources. And so when we say appropriate use of our resources, it comes back to that continuum of care. What are we already doing? And yes, this is another programming, but we intend to co-locate emergency services clinician, 988 call responders if the space allows for that, and then CRT and adult outpatient folks to add to our clinical capacity. We will need more staff, but we intend to bolster it with staff and programming we already have. We're hoping to reduce mental health crises, divert people from the emergency room, and then again, create those economies of scale by utilizing programs that already exist. So again, this is what we're already doing. This is upstream preventative education. We have many partnerships. We do a lot of training at Northeast Kingdom Human Services. And so I think we're well positioned to train our community, train the folks who would be working at this organization, and then overlap what we're already doing to bolster the program itself. Again, just another overview of my red statement, including what would be provided there, but it's really based on best practice. It's in partnership with others. It's founded in clinical treatment and is meant to divert people from the hospital who can feel overwhelmed. And anecdotally, in the last 6 months, I've had multiple calls from Sean Tester, NVRH, saying, we have 7 people in the emergency room that are experiencing mental health crisis. We're full. What can you do? And our care bed is full. And so there is really a deep-seated need for this program.
Kelsey, can we just stop there for a second? Do you mind taking some questions?
Yeah, absolutely. Do you want me to stop sharing for a second? I'll stop.
That would be great. Thank you. Leslie and then Alyssa.
I just want to clarify, because what you just said is that you were talking about people who were in the emergency department, because of crisis, no beds, no place to go, so they come to you. Now, I'm not hearing you're having any beds. So explain to me how that's going to work if a person's in crisis.
So this program would require, so there's been allocated funding for a physical space that would add 4 to 6 beds for the facility itself. And so that is part of this programming. So the funding that we're asking for is the actual programming for staff and running the therapeutic situation. And we are in the process of, through HCBS federal dollars, Allison could speak better to that, but she's not here, about where that funding's come from. But that will be done through a grant process for us to purchase a physical location that would meet the needs of this program.
Okay, so that's interesting. So you are including beds, it's sort of embedded in this whole process, in this whole program that you're proposing, that the space that you're gonna have. Okay. And I should know this, but I don't, I'm sorry. Could you tell me what CRT, there are a lot of acronyms sometimes, what CRT is?
Yeah, so community rehabilitation and treatment programming. And so that's really long-term supports and services for folks who have chronic mental illness. So usually, we do some brief intervention, outpatient work, home and community-based, but CRT is a specific program for folks who usually need support and treatment for a long period of time, sometimes a lifetime. And so we can see that sometimes due to their diagnoses or circumstances that they can cycle in and out of inpatient every 6 months or so, and don't have that designated spot that could be a diversion from the hospital when they're struggling. So it's just the programming is really for more intensive kind of support and treatment. And sometimes we have case managers, we have psychiatric nurse practitioners and psychiatrists that see these folks, and therapists as well. So they're wrapped a little more tightly and can tend to need more intensive services.
So we've been hearing a lot about the staffing problems and these, how do you expect to deal with that?
Yes, so that's a good part. I think the last part of that in the last slide here is saying that, again, as we're building this, we're trying to pivot, like Allison was saying, that there are untapped resources with peers. So we are connected with our recovery centers who do peer work with NAMI Vermont. And so how do we develop peers? I think that's an opportunity, an element of this program is saying we want to develop that, work with in conjunction and partnership with folks who already develop peers, and how can we work those in? There's also good data saying, like, who do people go and talk to first when they're having suicidal thoughts? It's not clinicians, it's peers. Those are the people they're going to want to talk to. And so building that into the therapeutic programming is going to be pretty important. So that's one avenue that we're trying to develop. Second part is we are asking for a rate increase. I think that's important part of this, and saying that we do need to bolster the programs that already exist by paying livable and competitive wages for the hard work that are happening. And we really think that this is an upstream investment, especially in these home and community-based services, which yes, it's an increase, but I think it's less costly than when people need to go to the hospital if we're diverting them out of the more intensive services. So yes, staffing is an issue, but we've had some success recently with some of the increases that we got last year. We need more, but we've seen a stabilization of staffing, at least recently, and intend to increase our pay rates here.
Great. Thank you. Liz, are you good?
Yeah.
Alyssa?
Thank you. And you actually answered half of my question. I was just wondering, where is this going to be located?
And I don't mean to be flip here, but in the Northeast Kingdom. And so we just haven't part of,
Can you?
yeah. So we were recently notified in the last couple months that those HCBS dollars came through. And so we are actively seeking out space. And although that can be tricky, we think that we've got a lot of community support and other organizational support for this. And we'll need to be thoughtful, but we're hoping really within the I-91 corridor, just for staffing, access to folks. We want it to be, within an hour's drive, which is actually quite challenging in our large catchment area from one end to the other. But we've identified some facilities and buildings, working with a realtor, and have our facilities director vetting those currently. So I can't say specifically right now.
So the intention is that you're going to take an existing space and renovate it for this purpose? And that's going to be with grant money, none of this money?
Yes. Yep.
All right. That was all my question.
Mari?
Is the request you have for rate increase, is that in the current governor's recommended budget?
No, it is not. And we're going to hear from Vermont Care Partners tomorrow.
Okay.
Art?
Yeah, let me get back to that. My question. How does, and it was mentioned, the Puck facility in Bennington was mentioned. Is this comparable to that? Is this the same type of facility as the Puck?
So it will have similar elements. And so let me just back up for 1 second. The reason we call this a front porch, which I have to give credit to our emergency services director, Josh Burke, is saying, as a community-based provider, we think about being a good neighbor. And so the front porch is kind of where you gather and you walk up to your porch, you talk to your neighbor. And so what's going on? How you doing? And so the idea is that you can come up, you'd be treated for what you need. And so the Puck model is not a residential model. It's a 23-hour kind of facility. So a kid in crisis can come in, be stabilized, leave, come back if they need to for a few days until they can ultimately be reintegrated back into school, was really the urgent need there. And so we would provide those urgent care. So we intend to be able to handle PUC urgent care for adults. And so same day access, you can come in, see a therapist, a peer, talk to somebody just during the day. If your situation or needs are more severe, then you can come further into the house. You can stay. We want to develop a living room model, which is really meant to be therapeutic in nature, which is kind of the difference to the emergency room, which it's just hard to have a therapeutic space in a hospital like that isn't specifically tailored to mental health crises. And so it's meant to be a continuum within the actual facility. And so, yes, we could have PUC-like program there, and we intend to do that, but also the overnight component, 2 to 10 day stay for that stabilization and treatment until you can get back into the community.
So 2 to 10 day stay.
Okay, thank you.
Kelsey, how many people do you think you would be able to help? Do you have any impact on, like, are there any numbers that you've been able to determine in the proposal?
So with capacity and also taking serious consideration staffing and things, we're planning to do 4 to 6 beds, and thinking that, that would be no less than 50% filled at all times and up to 95%. There's always like a little leeway that you want to give just for some of those things, but looking at our care bed, our wait lists, and there's already a need that's stacked up in the people that are going to inpatient and then coming back. And so I think there's that availability for that step down and up. And so I think there is that missing gap, but we're pretty confident this would be pretty staffed and utilized.
And then there would be a population that would come in to receive treatment or care, but not necessarily be in a bed.
Yep.
Need a bed. Yep. So there'd be kind of both. Okay. Daisy,
Yep.
and then I'll go back to Leslie.
I'm really thrilled that the Northeast Kingdom is finally getting a site like this, potentially. I also noticed that NKHS has a planning grant for CCBHCs, and this could potentially be a DCO or designated collaborating organization, especially since it would be 24/7 crisis services. So I wonder, have you considered using any of that planning grant money to inform planning for this facility, such as workflow or any of the positions that would be doing any of the crisis services?
Yep, absolutely. That was on my next slide.
We should just let you continue.
No, that's okay. No, but yes, so yeah, that was one thing I want to mention. And so we're one of 4 designated agencies that received a 4-year planning, demonstration, and implementation grant for certified community behavioral health clinic. And so they recommend that before you even apply, you provide at least 5 of those services. There's 9 total. And as we've looked internally, and I mentioned before, we're really trying to think about how do all of our services work in conjunction with each other. And so I appreciate the question, because yes, absolutely, we want CCBHC with developing peer services, the mobile crisis to Fidelity, our outpatient services, to work really closely with this program. And just, we are just this facility that has these supports, and it's based on a continuum, and that they're all working together through those workflows. And that's from intake to discharge, saying like, here's our spectrum of services, and that this would be one of them, but that we'd have access, and that our mental health substance use services would overlap with one another to strengthen each other. So yes, we are intentionally doing that.
Are you specifically leaning into those planning grant funds for planning this facility?
So I guess it's yes and no. I think there's a natural overlap and connection. I think our planning grant is really specific. Mostly it's for staffing that we have. And so we have a project director, a program evaluator, which would be working to study this to help support it. We've got peer specialists that would be working in conjunction to develop the program and support this program. So I guess, yes, we're intentionally including that in the CCBHC work, but as written, the CCBHC did not have this written into the grant as like a specific thing.
Got it. Thank you.
All right, one last question and then we'll let you finish your slide. Sorry, Kelsey. Go ahead, Leslie.
Thank you, Kelsey. I'm just trying to understand how this money all fits together. If I understand correctly, you don't have a facility yet, you're looking. So I'm thinking about the 1.6 of the general fund, 700,000. If there's no program yet, I want to understand where this money is going as you evolve, I guess, if that makes any sense. If there's no facility, do you need FY24 funds? I guess is where it distills down to for me.
Yep. And so our intention is to phase this. And so we do have some spaces. It's not centralized. And so we have a space where we could run puck out of. We've got an opportunity working with our community housing trust to have transitional housing that could house some of this programming. And so what we would be able to do is stand up some of the programmatic aspects. They just wouldn't necessarily be together in one building, which is really our intention, and what would really strengthen this program is it's got to be all together. So the urgent care, the puck, the 23-hour services, and some of the overnight residential services would look similar, but not quite like, the specific purpose-built facility that we're hoping to do. So yes, we would be able to use some of those funds immediately starting in the fiscal year 24.
Thank you.
Great. Thanks, Kelsey. If we haven't stolen all your thunder already with your remaining slides, we can go ahead and share your presentation again.
No, this is great. I prefer dialogue. So
okay, good.
This
helps us better understand it.
Let's see here. There we go. So I had talked about this a little bit, but I just want to emphasize that all of this planning for this program is not separate. We've really tried to break down silos, saying how does this really function together? And, I did just want to speak and emphasize our partnerships. And one thing that we've done, and I want to highlight, is our partnerships with law enforcement. And we've done a lot of work in working with Department of Public Safety, and we have 2 embedded clinicians in or mental health specialists in Vermont State Police. And so I did just want to note some, let's see, data here. And so again, talking about this can't be done without partnership. This can't be done without putting out a continuum of care. And this really can't be done without thoughtfully stitching together all of the programming in the community that already happens. And so really what we're trying to talk about is hospital diversion, more effective services, and thoughtful work. And so in December and January, in one location, we had 49 individuals were served, and we had 41 hospital diversions just from those interactions. And so we just define hospital diversions as clients that were screened and deemed fit to return to home or immediately provided appropriate placement in same-day screening or urgent care modalities. And so that fits in nicely. And I just want to read one story from staff. And so this is Tiffany Garces from our embedded folks here. So was involved in several welfare checks with a family. We're thankful for minimal and sometimes no police involvement in the process, given poor interactions with the police in the past. It can be scary to interact with the police, and we understand that. But Tiffany observed the beginning of reparation for those individuals, which positively impacted their views on police and mental health. Throughout this process, the clients were made aware that police were called. However, the discussions between mental health and police professionals were made with the intent to support the individual in crisis. As a result, the individuals involved in these situations felt accommodated before addressing the issue at hand, creating a more comfortable interaction during an uncomfortable time. And so I really want to emphasize the partnership. Law enforcement has been a great partner for us. And so we are funded to do embedded services with Vermont State Police as our other designated agencies. And we've also worked to kind of pivot and be responsive to Newport PD. So we're not funded for an embedded person, but we've been working to get our clinicians out into the community regardless. And so we currently embed a clinician with Newport PD for 24 hours a week, which has been a a great way to co-respond to mental health crises. And so I only mention that because having that in the community and then being able to escalate it, the only place to escalate situations is to saying you got to go to the hospital because there's nowhere else to go. You might need to be inpatient, wait for a clinical assessment, and then if you need, go to inpatient. And so when we're planning, we're looking for priority drop off that you may need to get medically cleared, but you can immediately leave the emergency room and head to the front porch. Or it could be a priority drop off for first responders like EMTs or police to drive straight to the facility and drop folks off for screening, assessment, and treatment.
Great.
And so, as you know, I'm sure you've been bombarded with statistics, but we have seen a great increase in the need for mental health, substance use, child, youth, and family services, the increase in anxiety, depression, suicidality, and that Caledonia and Orleans County have some of the highest rates of suicide and also substance use. And we've seen an increase in need for emergency services responses. We've also had intense workforce, so turnover is very hard, as you know. Developing relationships and is really important to the work that we do, not only for partners, but the people we serve. And so turnover is very difficult for us. Vacancies, we have open vacancies. Just as one example, we have whittled down our children's wait list, but we currently have just in this area, 23 children on our wait list seeking therapy. And so we have openings for clinicians. And then one thing I do want to highlight is that our 988 crisis call center has been fully staffed for 1 year. And so that is incredible and goes such a long way to doing good work. There is some downtime with their work, so they're able to help support and bolster other programmings. But one of the reasons we did that is when we started 988, I think we were offering $17 an hour. Working with DMH, we got that up to 20, and then working with Four Pines, which is a private entity, they pay a $3 an hour bonus, retention bonus. So every 90 days for every hour you worked, you get $3 an hour. So effectively, we're paying folks who are working in the call center, being mental health specialists, almost $50,000 a year. And so pay matters. And I just want to really emphasize saying the number one reason staff said they would leave their jobs in our most recent annual culture and climate survey is pay. And the second one was burnout. And so again, coming back to what this programming needs is not only the funding to run the programming, but also to bolster the other services. And I just wanted to emphasize that. And so that's included.
Great. So one second, Leslie. I just want to confirm, and I know maybe some of this needs to be with Allison, the money piece of this. So with this funding and the other funding you have in hand, whether it be from grants or partnerships, you feel this project in separate locations could start July 1st, 2024, and then move with the funding you already have in hand into one facility at some point in the future. And my point of the question is, if we provide this funding in the budget, you have what you need to start this program.
Yes.
Thank you. Leslie?
Thank you, Kelsey. The program sounds really interesting and exciting. And this may not be a question for you, but I'm curious to know, given the problem and the need, why the budget did not include this recommendation.
It is in the recommendation.
You said it's not in the budget.
The 10% is not in the budget.
Yeah, so
that's not a question for him.
I'm saying it's not a question for you. I get it. I just want it on the table for who's ever watching, whom I imagine there's some, to help me understand that.
Gotcha. Great. Any other questions for Kelsey Topper?
On page 8, the last two bullets. I don't understand what they mean. Can you just explain that a little bit?
Yep. And so I think, so in addition to providing mental health and substance use services, we also, as a designated agency, provide intellectual and developmental disability services. And so that's overseen by Dale. So But we often see higher instances of co-occurring mental health challenges with folks who have intellectual and developmental disability services. And we just think it's important to remind folks that, like, yes, the services are different, but they overlap in significant ways, and sometimes feel like because of folks who have an IDD diagnosis that a lot of their mental health struggles, which we feel pretty adamant about, can be labeled as IDD and not mental health. And so we just want to make a point of saying we serve all these folks and that they have mental health challenges as well, often at higher instances than the general population because of their diagnosis and histories, and that needs to be included in this conversation, is that we serve these folks, we intend to serve them through this programming as well, and that if they need mental health supports, we would provide that.
So that I understand it, what you're saying is the designated agency in your area now that would ordinarily deal with these people, are they dealing with them?
Yes, we already serve them, and so this would also be another support to bolster that. I just don't want, sometimes when we segment out through services, and I think we're just trying to make the point that intellectual and developmental disability services and folks with that diagnosis also struggle with mental health, and we just want to raise that and name that as well.
And so those individuals who are being served today through the DAs, through your DA, would also have the opportunity to use this front porch model of care.
Yes, if needed. Yep.
Okay.
All right, I just have last question. If you can't answer it, that's fine. The last bullet, what do you mean that people with developmental disabilities and autism are waiting for what?
So I will admit that this last bullet probably a little not connected to this, and use this for other advocacy. So I apologize if that's confusing, but we do have long wait lists for folks with intellectual and developmental disabilities, and housing is a big part of that in our shared living provider. And so there are crises that arise due to lack of housing, which actually turn into mental health crises. And so it is related if you're chronically worried about not having housing, and then that stress can lead to mental health crises. And so I think we're just trying to highlight that situation as well, and comes back to that upstream funding, which is saying oftentimes we need these higher levels of care, which are needed legitimately for people who are struggling, but can also be exacerbated by a lack of upstream and community supports that could support it. So it's emphasizing that issue and saying it's connected.
Thank you.
Great, we have a couple minutes because I want to make sure we're done before the announcements come on for our drill. Bobby, did you have a question?
Oh, just a recommendation to Kelsey, if you haven't chosen a site for the front porch, I recommend 3 wonderful towns that are all on the Interstate 91 corridor: Reigate, Barnet, and Waterford. And Waterford is actually halfway between Littleton and St. Johnsbury and has 2 interstates, 91 and 93. So I'm just saying, if you haven't found a site.
No, I'd really love to connect. I mean, that is something we've sat down and strategizing and saying, look, those thoroughfares, highways are important for staffing, especially in rural areas. How do you get there? Where are the population centers? And we want to be able to serve those rural areas, but that is a strategic kind of geographic issue we've been thinking about. So I'd love to talk about that for sure.
All right, you two can connect offline. Kelsey, thank you very much. This was extremely informative. And if we have any questions, we'll reach back out.